Thank you very much. And thank you all for coming. I don't know if this will work, which will work better. Dr. Giordano wrote to me last week. He was concerned that I should not make this talk too complicated and obscure. And I'm going to read to you what I wrote back because I think it's a good introduction to what I have to say. I wrote, if I'm going to talk about how practitioners think in the context of available models, I've got to go one step beyond Groupman. That's Jerry Groupman. It's probably more than one step. Everything that we've been struggling with over the past year or so, that's Dr. Giordano and I, has to do with the objective measurement of disease and the subjective experience of illness. I've got to say that the success of healthcare requires defining health not as the absence of disease, but as something positive. That's why the models don't work. That's why the DSM-4, that's the Diagnostic and Statistical Manual of Mental Disorders in its 4th edition, can't deal with the experience of suffering. So I'm going to talk about how subjectivity happens. I'm going to give them, that's you, the language, a language, and you've heard several types of language this evening, very erudite and literate language, with which to understand the decade of the mind if it happens. In any event, buckle up. I think modern medicine is a mixed blessing. The 20th century saw the rise of scientific medicine, and one might choose any number of events as the advent of modern medicine. Okay, how's that? No. Oh dear, what have I done? There it goes. Stan Reiser chose the moment that Laennec used his stethoscope to listen to the sound of disease, the measurable sounds of asthmatic lungs, or the sounds of a defective heart that was the cause of his patient's sickness. We can directly observe the phenomena of impairment of body parts and systems and record the observations and share them with other observers to study them. We compare and combine studies to characterize diseases and their treatments and to predict outcomes. This is science and the foundation of nosology, the study of noxious events. We measure anatomy, physiology, chemistry, and function to categorize the state of a patient into specific conditions or diseases. Nosologic catalogs, such as the DSM-4 and the ICD-9, the International Classification of Disease in its 9th edition, make sense of the myriad variables that practitioners confront. The practitioner catalogs her perceptions of her patient's condition within the model's matrix of symptoms and signs, the objects and events of the patient's condition, and the relationships among them. But you know all that. And you also know how practitioners observe the objects and events that characterize a patient's condition, how they gather the bits and pieces of the history and the physical examination, the laboratory evaluation, the imaging studies, and when we study the natural history and treated course of a disease, we must know that what we are studying, give it a consistent name. We must be certain that two investigators who share their data are actually studying the same disease. That's logical. With increasingly precise technology, scientific medicine catalogs diseases, deformities, injuries, and when the mechanism of disease is obscure, syndromes that are collections of symptoms and signs, whose measurement we define precisely. For we want our taxonomy to be sensitive to the variety of each condition, and yet specific enough to be diagnostically accurate. Effective treatment depends on accurate diagnosis. You knew that too. When the diagnostic criteria are strong, the diagnosis obtains sufficient certainty to warrant disease-specific treatment, a hypoglycemic agent if you have diabetes. The nosologic and nosology of Sydenham and Skinner's model of disease that is manifest in the ICD-9 and the DSM-4 permit us to do all that. And so we have the ICD-9 and the DSM-4. And when we have a rational system for the evaluation and management of disease, we call it healthcare. But is it really? To know what is healthcare requires knowing what is health, not just what is disease. It's strange, is it not, that through the debate on healthcare reform, no one bothered to define health. I'll get back to that, because it's related to a serious disturbance in this peaceful garden of rational, deductive, scientific medicine. The practitioner doesn't think deductively. Her first hypothesis about what's wrong with her patient probably forms before anyone has spoken a word or laid on a hand. Her first hypothesis might derive from the patient's posture or gait or facial expression. Each bit of new information supports or weakens the hypothesis or alternative hypotheses. Practitioners go astray when they get stuck in prejudgment. You probably experienced that once or twice, perhaps. Our minds do that sort of thing. How the practitioner thinks and how the models of disease are organized are very different. The models we construct to represent the objects and events of our universe, pertaining to disease or otherwise, are linear models. That derives from the mathematical and linguistic and pictorial symbols that we use to represent the objects and events of our universe. The accuracy of the representation depends in part on our ability to measure the objects and events modeled. Computers permit us to construct multidimensional models digitized from the organization of variables and parameters that we measure. The CPU analyzes their algorithms with linear computation, plug in a set of symptoms and signs and laboratory values and imaging studies, and out pops a disease differential with probable diagnostic and therapeutic interventions that the practitioner can use. But that's not how the practitioner's mind works. Doctors don't think in linear algorithms because the associative apparatus of the body-brain is non-linear. The process by which we know what is out there and by which we know that we are right in clinical problem solving or in any endeavor is non-linear. And if the doctor is worth her salt, she's also concerned about the patient's experience of the disease, injury, or deformity that is the cause of suffering and of illness and of disability. Suffering and illness are not thoughts. They are feelings, experiences that cannot be measured nor analyzed with linear algorithms. They are subjective experiences, as all experiences are, immeasurable, non-linear. Non-linear, we think we know what that means, but it's really an obfuscation, I think. We know what linear processes are, logical algorithms capable of digitization and computational analysis by Aristotelian and Quinean logic, like the DSM-4. But what is the non-linear process that we talk about when we talk about the practitioner's mind or about the patient's experience of illness and of suffering? You're going to hear a lot about this in the coming decade of the mind if it ever gets funded. The non-linear processes of mind, of consciousness, are described as emergent often enough, or supervenient. Well, no one quite knows what that means either, by the way. They're words only neurophilosophers could love, and they do. At least emergent is a positive word. Non-linear means nothing. It's just the negation of linear. You don't have to understand Wittgenstein to know that the negative of a word doesn't define anything. So I'm going to tell you one theory about what emergent properties of consciousness are like, and what it is to be nonlinear. This simple model does not tell you how consciousness happens, but it has a hint. This is a more complicated model, basically the same, and it doesn't tell you how consciousness happens either, but it also has the hint. Don't look at the details. You can pin this up on your refrigerator door if you're interested, but for the moment, the details are irrelevant. Can anyone see the hint in this model? I'll ask again. What I'm about to say is difficult. It's counterintuitive, and for some people, it's actually deeply disturbing. It has not been validated. Parts of it have been, but the whole has not yet. Remember, please, we are interested in illness and the experience of suffering. These are states of consciousness. They evoke emotions, but they are not themselves emotions, nor are they physical abnormalities of the body-brain. They are states of consciousness, subjective, immeasurable, incapable of digitization, characterization, or cataloging in any ICD-9 or DSM-4. Trust me, scholars and scientists have tried to measure and quantify suffering, and they cannot. Consciousness is the subjectivity of mind, the subjectivity of the human condition. What's out there is real. We're not sliding into solipsism here. What's out there is real, but your experience of it is unique and subjective. Like your first-person experience of the redness of a red ripe tomato or the sweetness of its taste. No one else can know what it is like for you to experience that redness. You can share it, you can describe it in symbols, but they cannot know what it is like to feel the redness of the red ripe tomato. Consciousness in awareness is the feeling of what happens. That's how Damasio put it. It's the experience of the remembered presence. Present, says Gerald Edelman. Consciousness is the experience of perceptual contents. Be not deceived. Consciousness is not the contents of perceptual experience, as you might read in the literature, and I suspect you will if you're interested in the decade of the mind. That erroneous definition is responsible for over 30 years of wasteful polemic in neurophilosophy and neuroscience. Subjectivity is what it's about, not contents. Perceptions have contents. Our experience of them have none. Our emotions have contents. They happen in the body. Walt Whitman told us that 150 years ago, and we're just figuring it out. During the decade of the mind, whenever you hear the word qualia, which is supposed to be the granularity of subjectivity, say to yourself, neologism, neologism, neologism. You don't have to make the sound, but it helps to vent a little bit whenever you hear that word. You can practice it. You're going to use it a lot. Okay, who sees the hint in the model? Anyone? You two are not allowed to answer. Anyone? It's in the two-way arrows. See them all? How many people in the room have used the expression, that resonates with me? You've heard this word before this evening. That resonates with me. You've used that expression before. It's a common expression. It denotes a feeling of confluence, a feeling of concordance. A feeling of being right, a feeling of connection. Well, that's it. Theoretically, that's how consciousness happens. Resonance. I'm going to go back for a second. Consciousness, the experience of perceptual contents, is the resonant, reverberating, iterative, reentrant, some people use that word, or recursive, philosophers use like that word, phase-specific synchronous oscillation of bioelectrical pulsations, probably in the gamma range, of neuronal and local field activity in massively interconnected, multidimensional circuits, networks, and systems among highly ordered cell assemblies in disparate parts of the embodied and situated global neuronal workspace, Barr's expression, of the body-brain, binding them, you heard that word before, around the representation of objects, events, and the relationships among them. Big sentence. That's a sentence that would make even Faulkner and James gag, I'm sure. I'm going to repeat it, actually. Consciousness, the experience of perceptual contents, is the resonant, reverberating, iterative, I put that in there because you've also heard that word this evening, reentrant, recursive, phase-specific, synchronous oscillation of bioelectrical pulsations in the gamma range of neuronal and local field activity in massively interconnected, multidimensional circuits, networks, and systems among highly ordered cell assemblies in disparate parts of the embodied and situated global neuronal workspace of the body-brain, binding them around the representation of objects, events, and the relationships among them. Consciousness doesn't happen in any place in the brain, it happens throughout the brain. That's why it's immeasurable. Perceptions that enter awareness appear to oscillate at about 40 hertz, and interestingly includes some dream work during REM sleep. Don't know why. Arguably, perceptions in consciousness that are out of awareness are those that resonate in other gamma frequencies between 20 and 100 or so hertz. Investigators call these realms of consciousness out of awareness variously: pre-consciousness, subconsciousness, access consciousness. Ned Block likes that one. Or subliminal consciousness. There was a reference to Cuidet's colleague Duhane in one of the previous talks. Subliminal consciousness is his favorite. Freud initially called them collectively the unconscious. He modified that later, but initially he called them the unconscious. Now, in the unconscious, perceptions of objects and events are capable of affecting other perceptions, as in optical illusions, of motivating behavior even out of awareness, like the Freudian slip, or something called blind sight, or the complex behavior of throwing a ball, 99% of the sensory motor mapping of which never enters awareness. Ball here, glove there, throw. You're unaware of 99% of the mapping that goes on in the brain of the sensory apparatus, the perceptual apparatus, and the motivational apparatus that does that. And some perceptions are capable of being encoded in memory to enter awareness later, when the stimulus is remote, such as the dreams of sleep. But all of this is consciousness, not just what's in awareness. Now, you're wondering, no doubt, how I'm going to relate this complicated theory to the problems of our fictive practitioner trying to understand, struggling to understand the experience of her patient. Science has no instrument to measure the subjective experience of oscillatory events. Illness and suffering, being subjective, are immeasurable. The practitioner understands the experience of the patient through the intersubjective experience that we call empathy. We can't measure empathy. We can't teach empathy. Medical students who are incapable of experiencing empathy can't be taught how to acquire it as a skill. We can teach a medical student, much as we teach a child with mild autism spectrum disorder, how to organize the awareness of perceptions of another's behavior so as to develop a theory of mind of the other. In this way, people with mild autism spectrum disorder, what used to be called Asperger's syndrome, learn to navigate complex social interactions to avoid conflict and to resolve conflict when it occurs. Doctors can do that too. The practitioner is capable of listening to the story of illness that the patient tells. Rita Sharon and Howard Brody show us that the practitioner, by listening patiently and carefully to the narrative of suffering, is capable of understanding it not in the context of an objective taxonomy, but by its subjective meaning in the psychosocial context of each individual patient. Dr. Giordano asked me to write a précis for this talk, and I wrote that a fitting epigram for the forthcoming DSM-5 might be, "There can be no type nor sort of human suffering for which there cannot be named a categorical disease." I should have been explicit that I was being sarcastic. The DSM-4 has nothing to say about the experience of suffering and never will. It's like the child with mild autism spectrum disorder. It can rationalize its observations of another's feelings, but it cannot enter into them. Entering into the feelings of another is empathy. No taxonomy of disease enables a practitioner to do that. The practitioner must help her patient to cure or control a condition, a disease, injury, or deformity that causes illness. But more importantly, and particularly when control is not possible, as when there is recurrent cancer or chronic pain or impending mortality, she must help her patient cope with the suffering of illness. Modern medicine will not care for our health until we relinquish the linear push-button mentality embedded in the nosology of disease. Relinquish the myth that health is the absence of disease. The irony and tragedy of the healthcare reform debate was that in trying to define healthcare, no one started by defining health. Let's begin. Health is the capacity to cope, to adapt, and to flourish in the presence of suffering. What we need, of course, is a taxonomy of health, not of disease. We need a model of the resilience of humankind, not of its vulnerability. Don't hold your breath.